Okay, so this we're recording. This conversation will start with a brief glimpse of an algorithm to approach hypercalcemia. We'll refer back to this algorithm as we parse the conversation that follows and the outline that follows. One of the earliest things that one should do in interrogating a case of hypercalcemia is determine whether this is driven by PTH or not. Far and away, most of these will be driven by PTH. Primary hyperparathyroidism is one of the most common causes. That and thiazide diuretic therapy are some of the two. It's one and two, the most common causes of hypercalcemia that we're going to be encountering. So obviously, if my PTH is high, primary hyperparathyroidism is one of the most common causes that we must think of. But tertiary hyperparathyroidism is another one that we as nephrologists will see pretty frequently. Those are the patients that, we're thinking about cinacalcet in. There's another entity, familial hypocalciuric hypercalcemia, that one needs to distinguish from primary hyperparathyroidism. That will allow us to review the biology of the calcium sensing receptor. You'll need to sort of put a thumbtack in that, because we're going to broach that the inverse of that physiology when we talk about some autosomal dominant hypocalcemia. Okay, so again, we're going to see mirror images of two diseases that revolve around calcium sensing receptor biology. So that should allow us to find understanding as opposed to memorization in the conversation on calcium disorders. On this other side, we're going to be looking at conditions that are autonomous from PTH regulation. And these are scenarios in which you might have an analog of PTH, that is PTHRP, driving the hypercalcemia, and then disorders of vitamin D metabolism or high bone turnover. Those are some of the things that are going to follow. All right, so let's go into this first step of the conversation where we're talking about pathogenesis and not just algorithms, and ground that conversation in an understanding of vitamin D biosynthesis and its regulators. Okay, couple of things that should be sort of foundational knowledge at this point, because you're prescribing these two medicines, is what is the difference between cholecalciferol and ergocalciferol? So they basically differ in the presence of this double bond in this side chain of this derivative of cholesterol, right? This is a steroid hormone that is made from metabolizing cholesterol as a backbone into either sex hormones, your aldosterone, and then also your vitamin D is a derivative of cholesterol, okay? And again, these differ by the presence of this double bond. That is the main difference between the two. We reference the ergocalciferol, which is derived from plants and fungi, as vitamin D2. Cholecalciferol is what you make in your skin, and what you eat or consume if you're eating meat. So this form of vitamin D is derived from those animal sources, okay? Including you as an animal, the vitamin D that you make in your skin. When you check a total vitamin D, you will sometimes get the breakdown that this is vitamin D total is 30, vitamin D2 is 30, vitamin D3 is undetectable, right? That would be a patient. How could we explain that? That would be a patient who's getting all of their vitamin D, or at least their sufficiency of vitamin D is coming pharmacologically from the ergocalciferol that you're giving, because they sit in the dark all the time, or they have loss of vitamin D in the urine through nephrotic syndrome. Those would be scenarios in which, again, the intrinsic synthesis of vitamin D is impaired or the clearance of vitamin D is increased. And then the remaining vitamin D that you see is what you're giving exogenously through the ergocalciferol. If you're giving cholecalciferol, the vitamin D3 would be, high or higher than the D2 that's present, right? The D2 may be undetectable in that scenario. All right, we take that first vitamin D type of vitamin D, which, by the way, can bind the vitamin D receptor and can do all of the things that calcitriol can do. The difference is that it's much less potent at the vitamin D receptor, but it is an agonist for the vitamin D receptor. Okay, the liver metabolizes these vitamin D let's call it precursors, right? Even though they are active at the vitamin D receptor, I'll use the term precursors, by hydroxylating this vitamin D at the 25 position, okay? And then you get, as you know, the 25 hydroxy vitamin D, and that's what I'm measuring by and large, right? When I'm measuring vitamin D, I'm measuring the 25 hydroxy vitamin D2 or D3. Okay, if you give cholecalciferol, you'll see 25 hydroxy vitamin D levels, which are D3 levels, which are higher than the D2. Okay, and again, that is processed in the liver by and large. And then the kidney has this regulated enzyme, this 1-alpha hydroxylase enzyme, which is also named through the cytochrome P450 enzyme nomenclature, right? But we know it best as 1-alpha hydroxylase. So this adds another hydroxyl group to this 25 hydroxyl vitamin D to make the 125 active form of vitamin D, the more potent form of vitamin D that binds vitamin D receptors. 125 hydroxy vitamin D, you can see the two hydroxyl groups referring to the 25 and 1-alpha hydroxylase effects on the parent molecule. Okay, now this is a regulated step. You can see that parathyroid hormone stimulates 1-alpha hydroxylase. Okay, and that becomes diagnostically helpful sometimes as we're trying to figure out disorders of vitamin D. Okay, if you have a patient, well, we'll talk about it, where I'll just anticipate. Primary hyperparathyroidism can have relatively low amounts of 25 hydroxy vitamin D, because you can think of it as pulling it forward into the active form. So it's not uncommon to have 25 hydroxy vitamin D levels that are low in primary hyperparathyroidism, and calcitriol levels that are going to be on the higher end of the normal range or overtly high. Okay, sometimes that can help us in distinguishing a case of primary hyperparathyroidism from tertiary hyperparathyroidism. It's not a best test, but that might be one clue. Sometimes you have mild CKD patients or mild to moderate CKD patients where you have a PTH that's elevated, and then the calcium is high. You're trying to distinguish that between tertiary and primary hyperparathyroidism. Using calcitriol levels can sometimes help you make that conclusion, because when it's, a patient who has significant CKD, you'll often see calcitriol levels that are predictably on the low side. But if in this CKD patient, their calcitriol level is, high normal unexpectedly in a CKD patient, that might give you a clue that this is more of a primary hyperpara as opposed to a tertiary hyperparathyroidism. Again, that's not a perfect test, but might give you some clues. So this would be a contextual data point that you might use in making a final diagnosis. Again, I'll allude to this when we talk more about primary hyperpara, but you often see 25 hydroxy vitamin D levels that are relatively low in primary hyperparathyroidism. FGF23 inhibits 1-alpha hydroxylation, which would also tend to explain why, even in a tertiary hyperparathyroid patient, right, even though they have high PTH, that inhibitory effect of FGF23 results in a downregulation of calcitriol. Phosphate is an inhibitor of 1-alpha hydroxylation as well. Okay, so PTH is a stimulator, FGF23 and phosphate are inhibitors of 1-alpha hydroxylation. Let's talk briefly about how FGF23 is regulated. It's derived from osteoclasts, so it's bone, which is the major source of FGF23. And this is a regulated hormone. The regulating or the stimuli for that regulation is most importantly phosphate. You need subtle amounts of phosphate retention in order to get pretty high FGF23 levels. Okay. This will become relevant as we talk about disorders of phosphate. We're going to talk a fair amount about FGF23 when we talk about disorders of phosphate. But nature has designed the system in an intelligible way. Phosphate stimulates FGF23 release from osteoclast. FGF23 enhances urinary phosphate wasting. So that's a nice, feedback mechanism, right? A closed loop. Calcitriol stimulates FGF23 activity or release. PTH is also a stimulus of FGF23. Okay. Phosphate retention is one of the main stimuli of FGF23 release, right? Because in CKD, we often have 125 or calcitriol levels that are low, but we'll see many-fold increases in FGF23 even before PTH goes up. And the presumption is that's driven in part by that relative phosphate retention, even though your phosphate's not high, right? The reduced renal mass, the tendency to phosphate retention stimulates FGF23. You maintain phosphate balance through the effect of PTH and FGF23, enhancing urinary phosphate wasting. Okay. Now, other things to think about. Alvin, we're going to see a patient today which has a deficiency, names, but a deficiency in this metabolism step in inactivating calcitriol, N25D. Okay. And this is the 24-hydroxylase enzyme. So there are some patients that have disorders of inactivation of vitamin D and actually can show up as a kidney stone former. And that's how a young man that we're going to be seeing this afternoon in Stone Clinic, Alvin and I, he presented. No other medical problems. His serum calcium was slightly high. His PTH was suppressed, so we knew it was PTH autonomous. And then when we check a calcitriol level in him, it was relatively high, even though his PTH was suppressed, right? There's the clue. So we started to follow that rabbit hole, right? We said, oh, your PTH is suppressed. Why do you have high calcitriol? Do you have sarcoidosis? Do you have some granulomatous disease that's causing excess calcitriol autonomous of PTH? What he ended up having is a defect in his ability to inactivate calcitriol to 1,24,25 hydroxylase. Oh, sorry, 1,24,25 hydroxylated vitamin D. Okay, you can see now there's 3 hydroxyl groups. It's now hydroxylated at the 24 position, and this deactivates, makes it much less active at the vitamin D receptor. Okay, the 24 hydroxylation also inactivates 25 hydroxyvitamin D. Turns out that your bioassay for 25 hydroxyvitamin D is not the best and will capture, many of these bioassays will capture 24, 25 hydroxylated vitamin D as well. So it can sometimes, your 25 hydroxyl vitamin D assay can sometimes overestimate the true reality of how much 25 hydroxy vitamin D you have. Okay.
Did that patient have an elevated FGF23 though?
We never checked the FGF23 in that patient. You're saying that because calcitriol levels were relatively high, maybe that FGF23 levels were high?
Yeah, like how would you distinguish between like the FGF23 deficiency versus that inactivation deficiency?
FGF23 deficiency. Okay, so that's a good point that that Danny is making, right? So he's revealing here that if I have a deficiency, FGF23 is a pretty potent regulator of 24-hour hydroxylase as well. So you tend to have low calcitriol levels when FGF23 levels are high, right? So FGF23 levels being high would FGF23 deficiency would cause a relative increase in calcitriol. FGF23 deficiency will tend to manifest with a tendency to phosphate retention and hyperphosphatemia. This patient didn't have any disorder of phosphate. Okay. FGF23 deficiency we'll talk about in disorders of phosphate. You can have forms of basically tumoral calcinosis because of phosphate retention in cases of FGF23 deficiency. Okay. All right, moving on to, I think we've said enough about the biosynthesis of vitamin D. Let's dive into some clinical syndromes. And first, we'll talk about some of the most common, and that's primary hyperparathyroidism. This is a situation in which you have hypercalcemia and a PTH which is elevated or at least inappropriately normal, right? You should see inhibition of PTH release as a normal response to hypercalcemia. I suppose that requires a. Are there any questions out there? I think I heard a. I guess Sophie, your baby's joined us today, so I will. It looks like you may have already muted yourself. Okay. Yeah, starting early. Highly encouraged. Okay. All right. So hypercalcemia, again, has PTH elevation, which is inappropriate. So let's talk about, again, that calcium sensing receptor. If I'm a cell in the parathyroid gland, one of my main roles is to regulate calcium. And I do that through expressing calcium sensing receptor. And when calcium binds the calcium sensing receptor, it inhibits the release of PTH, right? Parathyroid hormone is released by your parathyroid cells. Again, calcium sensing receptor would be an inhibitor of PTH release, right? That makes sense. So if I have a patient with hypercalcemia, I should see a PTH which is low. If PTH is high or in the normal range, that would be inappropriately elevated or inappropriately normal parathyroid hormone level. Okay. And that's a common way that primary hyperparathyroidism presents without a overtly abnormal parathyroid hormone level, but abnormal in the context of hypercalcemia. These patients, again, already said this, but I haven't said this enough, is that the parathyroid hormone is a phosphaturic hormone similar to FGF23. So we can see that negative regulators of apical transport processes in the proximal tubule are FGF23. Again, FGF23 binding to its receptor would inhibit these apical transporters of sodium phosphate, right? The sodium phosphate co-transporters. Right? PTH does the same when it binds its PTH receptor, inhibiting apical transport of phosphorus. So we tend to see phosphaturia or lowish serum phosphates in these patients with primary hyperparathyroidism. Okay. Many of these patients may have some bone disease, right? This is often a way in which you can see compression fractures. We have a patient on our inpatient service who's a 70-year-old lady who has plenty of reasons, underweight, Caucasian, who has plenty of reasons to have osteoporosis, But as an aside, we were doing a hyponatremia consult, but we noticed her calciums were running in the low 10s. We checked a PTH on her. She had a PTH that was in the 80s that was overtly abnormal, and she has osteoporosis. Probably we didn't do a DEXA, but she has compression fractures throughout her spine. Okay. Yes.
Say CKD or something that might actually be associated with PTH resistance.
How do I interpret an elevated PTH in those
No,
patients?
sorry, like someone has hypercalcemic with CKD4
Uh-huh.
and their PTH is normal, say 50, 60. Would you consider that an inappropriately unsuppressed PTH or?
Well, I think you can start from even the first two lines of what you presented. When you have a hypercalcemic CKD4 patient who has not been overdosed on active vitamin D or has even, less active vitamin D overdose, that already tells you something is unusual, right? So this is already should bias you to thinking about tertiary hyperparathyroidism, or we may be splitting hairs when we're just trying to discriminate between a tertiary hyperpara, which we'll talk about, and primary hyperpara, because there's significant overlap between the two. So I don't know if I undercut the essence of the question, but if you see, again, a hypercalcemic CKD4 patient who doesn't have an alternate explanation, and you see this PTH, which is not suppressed, right? If it's suppressed, you're going to be looking for, actually, we had an interesting patient, a patient who had silicone injections into the butt that caused granulomatous inflammation. She had advanced CKD and a PTH that was relatively suppressed for her advanced CKD. It was kind of in the, 50, 30, 50 range, but she ran hypercalcemic. And so in that case, that PTH is not high enough for me to say, I think this is primary hyperpara or tertiary hyperpara, even though that was a normal PTH in the setting of hypercalcemia, right? I had to say, well, this doesn't make sense. You had advanced CKD. You should have PTHs that are significantly higher. We went looking for a calcitriol excess, and that's what explained hers.
So I should just bias myself in these CKD patients with a normally high calcium to just go ahead and finish the workup as opposed to a person who's, just hypercalcemic but no CKD. I see an unsuppressed PTH. I often kind of stop the workup there and send to endocrine as opposed to getting the calcitriol.
Yes, yes. Let me make sure I agree with the first statement. The second statement is true. As common as primary hyperpara is, you do not need to check vitamin D levels in a patient who has a non-suppressed PTH and a hypercalcemia. You're done. All right. But you're asking, and let me make sure I agree with the first statement. If I have a CKD patient, significant CKD, let's say, not, the
CKD.
3A, with a GFR 59, we're saying significant CKD, and they have hypercalcemia. If their PTH is a 100, should I get the vitamin D levels?
Yeah.
Sure, but I'm pretty biased towards, with PTH of 100, I'm pretty biased. Well, obviously, look at meds, right? So one of the most common things you're going to see in that scenario is someone who's got overdosed with calcitriol.
Yeah.
That would be your most likely thing that's going to come to mind. So I don't know that I'm necessarily going to check calcitriol levels, right? I'm going to, as a next step, look at meds. And then if it's still not making sense, I will be thinking more deeply. Yeah, I think that's a general statement that one can consider.
Transplanted, does that PTH resistance slowly diminish over time that they've sort of built up from their CKD or ESKD?
PTH resistance, what do you mean by that?
Assumption. I assume that as CKD progresses with the high FGF23 and clotho and high phosphorus, my understanding is that there's more resistance to PTH, which is one of the driving factors for why PTH also increases or you sort of tolerate higher PTHs in these individuals.
Again, when you say resistant to PTH, you mean in its ability to raise the serum calcium?
Yeah.
Okay. All right. So that's how we're going to define resistance to PTH. Okay. So not, osteoclast doing something. We're saying definition is the ability to raise my serum calcium. Well, the problem with that one-dimensional understanding is that, okay, you've said that CKD patients, let me make sure I followed the train of thought. CKD patients have high PTHs, right? But most of them are not hypercalcemic, right? So the calcium is normal, right? But then you transplant this patient, and it's not uncommon that you still see that PTH elevation, and now you see a calcium that's high. And you're asking, I think, does this mean now that they're not uremic, they have more sensitivity to PTH, right? The problem with that simplified discussion is that you're maybe not thinking about the effect of now they have a functional kidney and now they don't have FGF23 excess. And so now their PTH is generating calcitriol, right? Is stimulating calcitriol production. And so you can say that the hypercalcemia that happens post-transplant is not as much about PTH resistance, but now the ability to make calcitriol. Okay? There is some PTH resistance from uremia. Okay? But I think I would not invoke the resolution of PTH, uremic PTH resistance, as the main cause of hypercalcemia in the post-transplant phase. To me, it's mostly this, the production of calcitriol now. You're cut off. 2 questions. Go ahead.
I frequently see patients with their PTH, even a year out, their PTH is not 30 to 70, it's now still 120.
Right.
And they have good allograft function.
Right.
And that's like normal to be expected, is what I'm trying to get at. Or is that not normal?
But like some kind of
Yeah,
variant
we
for here.
assume that's tertiary.
That's correct. Yeah, good
Yeah.
way to take our conversation. So when you see persistent hyperparathyroidism, which is common in the post-transplant phase, moderately elevated, sometimes so elevated, and hypercalcemic, that is a manifestation of tertiary hyperpara. And that allows us to kind of segue. Well, what is tertiary hyperpara? Tertiary hyperpara is a scenario in which that you have sustained parathyroid hormone stimulation, right? What is stimulating the PTH in these patients? Well, I'm having hyperphosphatemia. That's one of the probably the central players in this PTH excess that we manifest, right? I have hyperphosphatemia that's sustained. I have calcitriol deficiency, because calcitriol also affects, so you have a vitamin D receptor in the parathyroid cell, and binding of calcitriol to vitamin D receptor, or 25D to vitamin D receptor, is also a negative regulator for PTH release. So again, you have a low vitamin D. I'll put this in here. Stimulator of PTH release is phosphate. There's a direct stimulus of phosphate on PTH release. And the precise mechanism of that is not known, although there was a recent paper that I didn't digest fully that implied that maybe we're starting to understand it. It was so confusing. It was not an elegant, at least to me, it wasn't elegant, so I couldn't commit it to memory. But we don't quite understand how phosphorus directly stimulates PTH release, but it does in vitro models. Okay. Okay, so in a CKD patient, I have sustained hyperphosphatemia, I have vitamin D deficiency, so I have this sustained stimulus of this parathyroid cell to kick out parathyroid hormone. I actually stimulate multiple parathyroid cells, right? And so you get hypertrophy of these cells, bigger cells, right? And I get hyperplasia with that sustained effect on the gland. So you get a total gland mass, which is immense, in a patient who has been ESRD for many years before transplant. And so when they get transplanted, there is some involution of that enlarged parathyroid gland. It decreases in size, in mass, but there is a persistent big parathyroid gland mass. And that just total gland mass is one of the reasons why PTH is chronically elevated in the transplant patient. But in addition to that, put it in a green, okay? I actually start to get nests of adenomatous tissue within the hyperplastic gland. So you actually have areas that, if on histology, look like adenomas in these subtotal parathyroidectomies that are done for tertiary hyperparathyroidism. So think of it as a net result of both adenoma, akin to primary hyperpara, right? As well as foregland hyperplasia from sustained stimulus from calcitriol deficiency and hyperphosphatemia or phosphate retention. Okay, so that's why it's kind of splitting hairs when you call tertiary hyperpara and primary hyperpara. You know, it is, yeah. Yeah, we just, yeah, you could just say CKD associated. Okay. All right, so again, these patients may have bone disease, osteoporosis with very severe elevations in PTH. You have sometimes an upregulation of osteoclast activity and cell number, and you develop these brown tumors, right? The same brown tumors that you can see sometimes with astronomical PTHs in CKD patients. That's called osteitis fibrosa cystica. Okay. And then you can have some bone pain. Stones are another way in which primary hyperpara patients often present, and that's why we talked about the minimum workup when we talked about nephrolithiasis. I think most patients deserve a PTH as a minimum workup for a kidney stone presentation. Okay. We can see rates that are up to about 20% of primary hyperparathyroidism cases. Some people have just a nonspecific problem with, just upset stomach, and it can be constipation as well. Hypercalcemia, when severe, can cause constipation. And then there's just this, let's say, dysthymia from hyperparathyroidism that some people argue is independent of the degree of elevation of calcium. Okay, but obviously it's hard to make objective calls about what psychiatric effects of hyperpara and hypercalcemia a patient may be experiencing. Etiology, again, can be from the adenoma, which is the most common cause, right? In 80%, you're going to see a single adenomatous lesion within the four glands. Or you may have the four-gland hyperplasia, right? The diffuse hyperplasia in the remaining cases, right? So I mentioned here in adenomatous tissue, there is this somewhat disordered cell cycle regulation. So you get a clonal expansion of a parathyroid cell into these adenomatous, but not frankly carcinomatous areas of the gland. And then you can see changes in sensitivity to calcium at the calcium sensing receptor as well. Okay. Parathyroid cancer is a very uncommon cause of primary hyperparathyroidism. Again, PTH regulates osteoclasts, and so when PTH excess is manifest, you'll have bone loss. That bone loss also is the root cause of the hypercalcemia that you're seeing. Not only the reabsorption of bone, but also the effect on calcitriol, which surely I'll have here. Yes, parathyroid hormone stimulating 1-alpha hydroxylase production. So I'm also getting calcium absorption from the gut, right? So it's two sort of root causes of why the patient has hypercalcemia. Now, the parathyroid hormone also has its effect on tubular calcium handling. That's most well understood in the thick ascending limb. So we can see the PTH receptor there. I'm sorry, the DCT, we can see the PTH receptor there stimulating and regulating the TRPV5 channel. Here we are in the PTH receptor and the PTH hormone. Okay, calcium sensing receptor, I was conflating the two. Calcium sensing receptor is where we understand um, uh, this biology best in the thick ascending limb. There's calcium sensing receptor throughout segments of the nephron, proximal, distal convoluted tubule, it's been described. But the thick ascending limb is where we understand the biology of the calcium sensing receptor the best. PTH is where we, or DCT is where we understand PTH effects the best. Here's the cartoon. TRPV5 channel activity is upregulated by PTH binding its PTH receptor. So I'm getting more apical transport of calcium across this epithelium. But you'll see that PTH also stimulates other steps in calcium reclamation. Basolateral transport is upregulated through the effect of PTH on its receptor. And then interestingly, calbindin is a calcium binding protein, which maintains intracellular calcium concentrations low. Calcium is a central signaling molecule, and if you'll recall, in multiple steps of signal transduction and multiple um, uh, uh, biochemistry, steps in biochemistry, calcium is also a signal for cell death. So if you have high intracellular calcium concentrations, that would be bad. So free intracellular calcium concentrations are maintained low through the effect of calbindin. Okay, PTH stimulates the production of calbindin. That facilitates even more calcium reabsorption if I maintain the intracellular calcium concentration low. And then again, I'm pushing out the basolateral exit as well. Okay, so even though the net effect in the DCT is to increase calcium absorption, most primary hyperpara patients do not have hypocalciuria, right? If you stop here, you'll say, okay, well, if PTH increases reclamation of calcium, then patients should not be getting kidney stones. Patients with primary hyper shouldn't get kidney stones. Well, some patients with primary hyperparathyroidism actually have relatively normal urinary calcium excretions, sometimes on the low side even. And you can argue that away by saying, oh, well, PTH does regulate calcium reabsorption in the DCT. But usually the net effect of a primary hyperparathyroidism is that I have a higher filtered load of calcium, right? Because calcium is high, my glomerular filtrate has more calcium in it as well. So the filtered load of calcium is high, right? Filtered load of calcium is simply my GFR times my calcium concentration in the glomerular filtrate, right? So if my GFR is normal and I have a high serum calcium, my filtered load of calcium is high. So even though I may get to the DCT, and in fact, I am stimulating calcium reabsorption in the DCT through the effect of PTH, the high filtered load of calcium may still result in in hypercalciuria. Okay. There's another explanation. The other explanation is, again, I have calcium sensing receptors throughout the nephron. I told you it's best understood in the thick ascending limb, calcium sensing receptor. It's one of your Bartter syndromes. Okay. But if I have hypercalcemia and it binds the calcium sensing receptor in the thick ascending limb, in the proximal tubule, thick ascending limb and proximal tubule, I inversed it even though I drew it correctly here. Those would downregulate, okay, those inhibit the paracellular transport of calcium in these segments. Okay, again, I have calcium sensing receptor in the proximal tubule as well as the thick ascending limb. I believe I've described it in cartoon form in the thick ascending limb. You can see that when I bind the calcium sensing receptor, I regulate paracellular transport through these claudins. The net effect is reduced calcium absorption, so hypercalciuria, right? So now you can see the schizophrenic effects of PTH and calcium sensing receptor that converge to reveal, in most cases, hypercalciuria, but not always. Okay, one last point I'll put in there to twist it. Remember, I told you, most patients with primary hyperpara will have hypercalciuria. Some are normal calciuria, normal calciuric. Uncommonly, you can even see hypocalciuria. Okay? One reason you might see hypocalciuria or normal calciuria in a patient with primary hyperpara is because, as I mentioned, if you have primary hyperpara, you may ultimately start to get vitamin D deficient. Okay? Vitamin D deficiency may ensue either through diet and, they ultimately, the half-life of calcitriol fades or calcitriol levels fade. And so I have a substrate deficiency, right, that retards the production of more calcitriol. I'll ultimately manifest a 25-hydroxylase deficiency. And so I can't even generate more calcitriol. Okay? So that would result in some of these patients having normal urinary calciums or even sometimes low urinary calciums. Okay, that'll become relevant as we talk about discriminating between FHH. The punchline, which I guess I'll backfill, is if you have a urine calcium that's relatively low, before you label it familial hypocalciuric hypercalcemia, right? The distinguishing feature is the low urinary calcium. You should replenish the 25D deficiency and repeat. Okay? All right. We talked about the effect of PTH on phosphate wasting. I think we can move on. Okay, so hypercalcemia with inappropriately normal or elevated PTH is the classic feature, right? Some of these patients require repeat testing because, they may only have subtle elevations in calcium that are not clearly manifest. Let me give you this important point that becomes relevant in more than just primary hyperpara. Remember, one defense against the hypercalcemia is the actual hypercalciuria, right? If I'm dumping calcium in my urine, that defends me against hypercalcemia, right? So some of these patients become manifest when you have a drop in GFR. Okay, so the primary hyperpara actually has a calcium that is 10.1 as long as the GFR is preserved. But then they have an AKI episode or a volume depletion episode or just loop diuretics even though loop diuretics would be expected to increase urinary calcium. If you get someone volume depleted, you start to reabsorb more calcium proximally. The GFR starts to drop. And so my hypercalciuria is no longer as robust or even starts to drop into the normal or low range. So then my serum calcium starts to rise. Okay. Another analog or another example of that principle in motion is the patient with calcitriol excess. So here's a classic picture that I see, a calcitriol excess like sarcoidosis. A patient with sarcoidosis has calciums of 10.1, okay? Now they start to manifest sarcoidosis in the kidney and have granulomatous infiltration of the kidney, and GFR starts to drop. And these patients have this crescendo serum calciums that go to 13 in just a matter of days to weeks, even though you wouldn't have expected that their calcitriol production has dramatically changed, or their sarcoid burden has dramatically changed. Either some iatrogenic cause of acute kidney injury results in a reduced filtered load of calcium, or that granulomatous infiltration of the kidney just starts to drop the GFR, and then the calcium's blast off. So the take-home message is intact renal function protects you against hypercalcemia. Okay. Myeloma patients, similarly. Myeloma patients trucking along with low or normal calciums, and then they have some hit, and then their calciums blast off. Okay, that's another example where we see this pattern. Bottom line is intact renal function protects you against hypercalcemia in some of these conditions. Okay. There is a phenomenon that you're going to encounter that has some squishiness to it. It's something called normal calcemic primary hyperparathyroidism. These are consults you might get, or endocrine often gets, where PTHs are high and calciums are always normal. What you should exclude is vitamin D deficiency, but sometimes you replenish the vitamin D and they still have persistently elevated PTHs, but their calciums are normal. Okay, so the definition is in the name here, right? Normal calcemic primary hyperparathyroidism. Just because we have a name, it doesn't mean we necessarily understand it, but it is something that you can put a label on and say, okay, consult done. This is not harmful. It appears to be not harmful to the patient. It does not appear to be sort of a form of primary hyperparathyroidism that results in bone loss and downstream adverse clinical effects. So often you can provide reassurance, and after again repeating the test with vitamin D replacement, right? You replenish any vitamin D deficiency. And then if you see repeatedly the calcium is normal, call it normal calcemic primary hyperpara and say, well, this doesn't seem to be harmful to you. Okay. Well, they're not hypercalcium, because in that scenario, you might suspect that they would still be predisposed to kidney stones, right? So in this normal calcemic primary hyperparathyroidism, we're not seeing kidney stones, right? You would also still see, again, that they'll have bone loss, progressive bone loss. If it was all just, well, intact renal function defends you against hypercalcemia. That's not, again, this condition. Correct. All right, 24-hour urine calcium, again, is part of the evaluation of these patients, so you can discriminate the primary hyperpara from FHH, okay, familial hypocalciuric hypercalcemia, okay? So urine calcium is that critical decision point. I think I've made this point before, and I'll make it again. Even though the textbook says that if you're discriminating Gittleman's and Barter's, urine calcium is this great test for you. Okay, I've told you there's flaws to that, and I'm reiterating there's flaws to the urine calcium in perfectly discriminating primary hyperpara and FHH. There's genetic testing for FHH. People have used genetic testing to prove you have FHH, and then tried to then assess the utility of 24-hour urines to discriminate between the two, and it reveals it's not a perfect test. It's a pretty good test, but it's not a perfect test. Okay, now it is perhaps better to use a calcium to creatinine clearance ratio. This is nothing more than a fractional excretion of calcium on a 24-hour urine test. So if you were to do a 24-hour urine fractional excretion of sodium, it would be calculated the same. You're just going to replace the sodium terms with calcium terms. You'll replace the spot sodium terms with 24-hour urine terms. Okay? So this is a recognizable formula. This is nothing more than FENA changed to FECA, I guess. Okay? Fractional excretion of calcium. And then you use a 24-hour urine. 24-hour urine smooths out the peaks and valleys that you evidence in your daily experience. When you take in sodium in your meal or calcium in your meal, you have hours of hypercalciuria or increases in urinary calcium. When you're fasting and you're volume depleted and you're doing your 5 p.m. consult, you're having hypocalciuria. Okay. So doing the 24-hour urine smooths out those curves and can tell you, yes, the net total is a relative hypercalciuria. There's another benefit of doing a fractional excretion of calcium, and that is when you have CKD, because your urinary calcium because your filtered load of calcium is low, right? This is my filtered load of calcium. It's the product of my GFR and my serum calcium. So if I have diminished GFR, then my ability to mount hypercalciuria will be blunted. But you can still interrogate that case and say, well, corrected for the GFR, this patient has a relatively high urinary calcium excretion rate. And so this fractional excretion of calcium expressed as a percentage of the filtered load, right, corrects for any decrease in the filtered load from low GFR. So no longer are you dependent on the absolute calcium excretion rate. You're now expressing calcium excretion as a percentage of the filtered load. That's what a fractional excretion is. So this corrects for any problem with GFR that may confound the 24-hour urine calcium. Okay, and some cut points that are used for FHH is 1% or less, and primary hyperpara is generally greater than 2%. You can see that there's a gray zone here, right? People fall in the middle, so there's plenty of patients that you might need to do additional testing to finally make a diagnosis. Let's end on treatment of primary hyperpara. So imaging is done for evaluating for surgical options, right? It helps you discriminate between the adenoma and the foregland hyperplasia. And we generally reserve surgery for the adenoma patients, right? Rarely you might do a foregland parathyroidectomy with autoimplantation. We usually reserve that for the tertiary hyperpara patients. But by and large, we're treating mostly adenomas with surgery in primary hyperparathyroidism. Okay. Now, these are not perfect tests. So just because you have a negative sestamibi scan doesn't mean you're not dealing with primary hyperpara. Many people don't kind of realize that. They say, oh, I'm kind of at my wit's end. But you can say, well, the sensitivity of a sestamibi scan is only 80%. So some patients with a negative sestamibi still go to the OR, right? Where the surgeon goes in and samples the draining veins to localize the overactive parathyroid gland, and then use intraoperative ultrasound to find the gland even when sestamibi was negative. They take the gland out, and then they confirm that the PTH drops to define success. Okay? So the point I'm trying to make is that and some surgeons say don't get imaging before you send them to me. I'll make that call. So some surgeons, maybe it's older surgeons or more experienced surgeons, say, neck exploration is what we're going to do, and I'll do intraoperative localization, and we'll take care of it that way. Okay. Ultrasound is often done at our institution. We often do ultrasound plus sestamibi for localization. And there are more sensitive tests like a CT scan for patients that are really, the surgeon really wants the preoperative imaging in order to pursue planning or to strategize prior to surgery. Sometimes they'll go to CT scan. Okay. Treatment is generally in more recent times, most patients are going to have surgery. It's a low risk surgery. My mom's had this surgery. It's a day surgery, right, for most people. Okay. And that's because we are trying to avoid some of the complications, especially reduced bone mass. And so if you're a young patient with primary hyperpara, now these are some of the, even for asymptomatic patients, surgery is indicated if any one of these things or more is achieved. So if you have a primary hyperpara patient who's not even all that hypercalcemic, hypercalciuric, no bone loss, but they're just young, and they're going to have many life years of exposure to this overactive parathyroid gland, you send them to surgery. Okay? If they're not so young and they have a lot of morbidity, you might use more conservative things. You know, is the calcium high enough? Do they have evidence of bone loss? And they, you know, and the bisphosphonates are not working. GFR being low is also a single decision point, because the thought is with hypercalciuria, calcium oxalate nephropathy may be a cause of progressive CKD. And so that might be a reason to address the hyperparathyroidism, certainly kidney stones, or nephrocalcinosis, and then just having hypercalciuria is a decision point. Okay, you can opt for medical management of certain patients. That would include protecting the bones and then trying to downregulate PTH. Let me make some conceptual points and then we'll end. Okay. The effect of cinecalcet, I've erased my parathyroid gland. So if I'm a parathyroid cell, right, remember I express calcium sensing receptor, right? So cinecalcet is a calcium mimetic. It doesn't bind in the same binding groove as calcium does. Oops, I shouldn't put it as a calcium. Oops. So cinecalcet binds, I'll just put a little dot here in my molecule. It doesn't bind in the binding groove. It binds separate from the calcium binding cleft, and it sensitizes the calcium sensing receptor to any ambient calcium that's present. So it enhances the inhibition of PTH release, right? Of any given calcium. It sensitizes the calcium sensing receptor to that calcium and makes PTH, it suppresses PTH release. Okay, so that's good if you have primary hyperparathyroidism. But here's the other edge of the sword. What happens if I sensitize this calcium sensing receptor with the effect of cinecalcet, right? This calcium sensing receptor was telling my proximal tubule what to do with paracellular transport of calcium. Okay, if you're sensitizing this calcium sensing receptor, which is saying, okay, I have, you know, lots of calcium around, right? If I have lots of calcium around, I am going to inhibit paracellular calcium reabsorption, right? I'm affecting claudin activity, and I'm going to reduce paracellular calcium reuptake in the proximal tubule. I'll do the same in the thick ascending limb, right? So I'm inhibiting calcium reabsorption in these two segments. I can cause a net hypercalciuria. Even though I've suppressed PTH, serum calcium may go down, right? So my filtered load is going down, but I'm also tending to reduce the reuptake of calcium in the proximal tubular and thick ascending limb. So if you're going to use cinecalcet to medically manage a primary hyperpara patient, you should follow their urine calciums. Make sure the net result is not hypercalciuria. Okay? Questions?